Another relative contraindication for RTPA in ischemic stroke is if the patient presents with um, seizures as well, as in aesthetic history. The patient tells you that the patient actually had seizure, and at the end of seizure they experience stroke-like symptoms. This has to alert you to, to something called a post-ictal state. Usually after a seizure event, the person would be rendered weak. They would either experience partial or usually generalized weakness or paralysis, and this is called Todd's paralysis or Todd's paralysis. It occurs because of one of these two scenarios. It could be due to an exhaustion of neurotransmitters after excessive neuronal firing within the motor units of the central nervous system, or it could be due to a relative hyperperfusion due to vasoconstriction after such an exhaustive um, event in that region of the brain. So the patient would, in fact, present with weakness, and it could mimic a stroke. So if you were to give the person RTPA, if he had not had experienced stroke, it would not actually cause any adverse reactions according to some literature. But I mean, you're ultimately just giving the person a drug that the body doesn't need, so it could wreak anything in the future. So in that sense, it's a relative contraindication. If you were to do a CT brain to look for areas of infarction in cases of post-ictal state, you may or may not find a relevant arterial or vascular defect. Usually, if there's an area of infarction along with a vascular defect, it would point to an ischemic stroke. But this is not the thumb rule. It does not mean that if a person's CT brain shows area of infarction without an arterial defect, the person does not have stroke. That is not necessarily true all the time. So you do need a high degree of suspicion when a patient presents to you with history of recent onset of seizures.